We'd like to welcome everyone and thank you for joining us on this Friday for today's Teen Network webinar. Today's webinar is on assessment and treatment implications for early psychosis programs with our presenter today, Dr. Barbara Walsh. Today's webinar is hosted by the EASA Center for Excellence at Portland State University. They're a partner of the National Teen Network for Children's Behavioral Health, which is operated by the Institute for Innovation and Implementation at the University of Maryland.
Thank you. Yes, let me introduce myself first. My name is Ryan Melton. I'm the Clinical Director for the EASA Center for Excellence at Portland State University. As mentioned, we are co-hosting this webinar. EASA is an early psychosis program that has been working with individuals since 2001 and been partnering with Barbara Walsh for almost all that time, maybe about half of that time. But it's my pleasure to introduce our speaker today, Barbara Walsh. She's back again by popular demand. She hosted a webinar on just what Psychosis-Risk Syndrome is a few months ago, and now she's back to talk about a more further assessment and then treatment of Psychosis-Risk Syndrome. She's got an amazing amount of experience. She's the clinical coordinator for the Prime Clinic at Yale University School of Medicine. She oversees evaluation and treatment performed on young people at the clinic and is responsible for providing psychoeducation on the early warning signs of serious mental illness in young people to a wide variety of communities. And then also responsible for training professionals here in the U.S. and abroad. She's trained us at EASA many, many times and is amazing at doing so. And the training that she specifically does is on the assessment instruments used to diagnose the early warning signs of a serious mental illness in young people. She co-authored the book, The Psychosis-Risk Syndrome Handbook. Barbara, welcome, and thank you for presenting again.
Thank you very much, Ryan, for those kind words, and thank you, everyone, for joining us today. I'm really very pleased to be here to talk to you about the assessment and treatment implications for early psychosis programs. You know, I've been privileged to work in this field for over 20 years, and it appeared to me in the beginning that we were moving along kind of at a glacial pace, a bit slowly. But I have to say that in the last 6 to 9 months, that has changed drastically. And the information that we're coming up with that is coming out now, I really feel like if I don't stay on top of it on a weekly basis, I'm going to be behind the 8 ball. So I really welcome this opportunity for all of us to get on the same page about this very valuable work. And I'd like to just start with the basics of what we know regarding the status of at-risk persons. So we definitively know that they are diagnosable, and I'm going to talk about the validity of the diagnosis in another slide pretty soon. But we do know that we can accurately diagnose these people for being at risk, and that they are symptomatic. They are having experiences that are causing them distress, either because they're cognitively impaired or they're functionally impaired. And this causes them to seek treatment. And therefore, it's up to us as the caregivers to provide them for a treatment that helps alleviate some of that distress and interference. And they are indeed at risk of developing a more serious mental illness. We know that despite all the recent advances in treatments and medications and the rehabilitation programs, that most patients still follow a course with poor social and occupational functioning. So most of the patients who meet criteria for psychosis still have a very difficult path ahead of them. And we know at the time that psychosis comes to fruition, already present is measurable cognitive impairment, measurable gray matter volume loss, damaging social development losses. Unfortunately, most young people who enter the mental health field for psychotic symptoms enter it in the back of an ambulance or a police car. And that can be very traumatizing, and it can be very stigmatizing. As well as once they've crossed that threshold, they have a diminished capacity to actively engage in treatment. And if you think about the definition of psychosis, a severe mental disorder in which contact with reality is lost or distorted, if I've lost contact with reality, there's a good chance I'm going to be a bit paranoid. And I'm not going to trust my treaters. I'm going to be suspect of their motives or their intentions. And if I am, I'm less likely to be an active participant in my treatment plan. If I'm still in that at-risk phase, I recognize that what I'm experiencing is different or odd, and I want help. And therefore, I'm much more likely to be an active participant in my treatment plan. And of course, if I am, that treatment plan has a much better chance of being successful. As I go forward with the evidence about why we should intervene during this at-risk phase, I consciously chose to pick references that were more current in the last 2 or 3 years, and then some earlier ones from back in the early 2000s. And the reason I did that is to really emphasize the fact that over these 10 years, we have been validating the same information over and over again. And that is that intervention during the ultra-high risk or at-risk phase may prevent, but certainly delays or reduces the impact of psychosis. As I mentioned, there are substantial psychosocial disabilities that develop during this phase, and if we intervene early, we can reduce those. Early intervention also reduces the duration of untreated psychosis or DUP, and we know that a longer DUP correlates with poor treatment outcomes. Pre-psychotic intervention reduces the likelihood of behaviors or incidents developing that may stigmatize the person. And very, very interesting in the report from the PACE Writing Group is that young people who later develop psychosis are less likely to need inpatient care if there has been intervention during the at-risk phase. In 2015, there was a large research project completed that showed that the differential risk for developing psychosis when someone was identified at meeting that high-risk state was statistically significant when compared to a help-seeking comparison patient, in that they were truly at risk for developing psychosis as opposed to another mental disorder such as bipolar disorder, non-bipolar mood disorder, or perhaps even anxiety disorders. And their findings went on to further suggest that being in this clinical high-risk state or at-risk phase is actually an earliest phase of psychosis. And it was very interesting to me that back in 1980, there was a study published that stated that the changes in the at-risk state might actually indicate a pre-psychotic mental state, and that there were factors, enhanced coping and increased social support in particular, that could prevent but definitely delay or modify the progression to psychosis. Thus, they drew the conclusion that it was also a pre-psychotic state. And I find that very interesting because it's one thing to know you're at higher risk for developing psychosis. It's another thing to know that you're at higher risk for developing psychosis, but that there are things that you can do to help change the course of that progression. One of the criticisms of early psychosis work from the very beginning has been dealing with false positives. And we've made a lot of progress in this area now. Many of you might be familiar with the Cleveland Clinic. They were responsible for the development of risk calculators for breast cancer and cardiac disease. And they worked with the Naples Consortium of Early Psychosis work to develop an individualized psychosis-risk calculator that lets us put in 8 factors that then evaluates that individual's risk for developing psychosis. So the standardized assessments evaluate your risk, increased risk of developing psychosis as opposed to the general population. The risk calculator looks at your individual risk for developing psychosis. And what has been established with the use of the calculator, that treatments associated with greater risk to the patient, so for example medication side effects, or perhaps greater, they imply greater cost to the healthcare delivery, like very time-intensive psychotherapeutic interventions, that we should reserve those for people who are higher than the median levels of predicted risk, so greater than 16%. And the cost-effective and time-effective treatments with benign side effects should be used for those with less than median rates. And this really is the first comprehensive, concrete guidelines for treatment options with this population. We very often, have to look at how the different phases of psychosis or schizophrenia impact patients. And we, of course, have the premorbid level of phase. This is when people are very young and may have absolutely no symptoms at all, but they might know that they have a family history of being at higher risk for developing a psychotic illness. And then we have that middle phase, which is the clinical high risk or at-risk phase, where a person starts to develop a decline in functioning and the beginning of mild but not yet fully psychotic symptoms. And then that last section, the blue phase, is when someone becomes fully psychotic. And where that yellow meets the blue is the onset of the illness. And then at that bottom lower point is when people enter into the first appropriate treatment for psychosis. Now, it doesn't mean it's the first time a person gets mental health care. They may be floating around the mental health care system, but they've been misdiagnosed and haven't received the appropriate treatment for a psychotic illness. And that little line there between where the yellow meets the blue and the first appropriate treatment is called the duration of untreated psychosis, or DUP. And all of the research tells us how important that is to a person's long-term prognosis. Typically, it represents a 2-year period of time. Once the person does get appropriate treatment, you'll see from the diagram that they rebound, but they never rebound back to their premorbid level of functioning. And the PACE writing group actually went on to define this even more in detail, especially in terms of the blue phase of the illness. So in that first section where there's increased risk but no symptoms yet, basically what they suggest is that there be individual and family education and drug education so they understand how those life choices can impact their risk. And then in that at-risk phase, the clinical high risk or genetic risk and decline, what they recommend is secondary prevention such as psychoeducation, CBT therapy, SIT therapy, family-focused therapy, multifamily groups, substance abuse work, natural substances like omega-3 and D-serine, and antidepressants. And then in the blue phase, in the early part of that, the first episode, Psychosis, they encourage psychoeducation, again, CBT, FFT, MFG, substance use work, atypical antipsychotic medications, and social and vocational rehabilitation. And then further out in the blue section, where people have incomplete remission from that first episode of care, they recommend continued FEP work with emphasis on medical and psychosocial strategies to achieve remission. And further along, where there's incomplete remission, a recurrence or relapse with residual symptoms, they encourage continued FEP work with emphasis on relapse prevention. And then if there's multiple relapses with functional deterioration, they recommend continued FEP work with emphasis on long-term stabilization. And then for that small percentage that has persistent or unremitting illness, they recommend continued FEP work with emphasis on the use of clozapine and social participation despite the ongoing disability that may be accompanying that phase. Everyone agrees that the elements that are important to any early intervention program should include assessment, engagement, wellness issues, monitoring very closely for progression, and again, not, of course, most importantly, because we don't want people to worsen and progress towards psychosis, but also to be able to capture the nuances of improvement, because that information is crucial for us to know what treatments truly are evidence-based and which aren't. Individual therapeutic interventions, family interventions, group interventions, crisis management. Just because a person is not fully psychotic does not mean that they won't have crises that need to be addressed. And transition interventions, both transitions towards psychosis, but also transitions towards remission, because care would change then as well. The assessment piece of this part of treatment, it's very crucial to remember that risk assessment is completed only on a help-seeking population. We don't want to do this on people who are not expressing distress or discomfort or interference from their experience. This really should be done with help-seeking people only, and therefore there needs to be some method of pre-screen. And most early episodes clinics, there's a variety of ways that you can pre-screen. There are some standardized ways, the PQB or the prime screener, but there are many individual, doing a phone screen or doing a pen and paper screener before you actually do the SIPs or the CARMs with the patient. And the SIPs and the CARMs are the two validated assessments for determining the at-risk state. And because assessment is the first step in treating these patients, it really is helpful if the early identification clinic can treat both at-risk patients and first episode patients. So here at Yale, we kind of triage both of those population groups through one funnel. And that way we can evaluate where they are in the course of that illness and then triage them either to a early at-risk clinic or to a first episode clinic. And also, if we take them in to the at-risk clinic and they do go on to develop psychosis, then we have the availability of that first episode psychosis clinic to transition them to, which makes it a very seamless transition. But in saying that, I also want to emphasize the fact that you have to have a clear definition of what you define first episode psychosis for. And I'm not advocating for any particular definition of that, just that there be a clearly defined definition. Some clinics will make a defined first episode as within the past year. Others might go as far out as 3 years. Some have limited as much to 3 to 6 months. And again, I'm not advocating for any particular definition, just that you be clear on what your definition is. And the other thing is, I just want to emphasize that an at-risk assessment should never be a standalone assessment. There should always be some follow-up clinical interviews that help clarify the total clinical picture of the young person, such as the SCID or the PANS or, the COG-DISC, other standardized assessments that can help specify information. Very, very important when we're talking about this work that we emphasize the importance of differential diagnosis. I always emphasize to people that even if you're a licensed psychiatrist or a licensed psychologist, that doesn't mean you can use these specialized at-risk assessments. They really require specific training because of the importance of this differential diagnosis. Because as we know, the same symptom can be indicative of many different mental disorders. Just like in physical health, you could have a headache today because you forgot your eyeglasses and you have a headache. Or you could have a headache today because you're really stressed out and your blood pressure is elevated. The symptom, the headache, is exactly the same in both cases. But what's driving that symptom is different. And if we're not familiar and if we're not accurate in what's driving a symptom, we really can't come up with the most optimal treatment plan. So being able to make that differential diagnosis is very, very crucial. Early warning signs and symptoms certainly appear in young people before the psychotic illness comes to fruition. There is a substantial amount of disability and distress associated with those symptoms, a long period of time before formal diagnosis. The most increased risk for developing psychosis when you're at risk is the first year. But we know that you can stay at risk for as long as 10 years. People who are experiencing these at-risk signs they warrant a full assessment and a monitoring and intervention, even though full-blown psychosis has not yet emerged. And really, if you think of the ethics of this, these people are distressed by the experiences they're having, and they're coming to mental health professionals for help in keeping that from being so distressing. And ethically, we are driven to help these young people. It is crucial to remember that, they deserve this treatment, not just if they develop psychosis, but even for what it is at that time, and for the comorbid diagnoses that may be accompanying that at-risk state. A thorough assessment, as I mentioned, is definitely warranted, including an at-risk measure, including family history, safety measures, differential diagnosis measures, perhaps some assessments of depression and anxiety, certainly substance use assessment, quality of life measures, neurocognitive functioning. You want to understand the clinical picture of that young person as much as you can. It's always a bonus if you're in a position to include some biological checks like MRIs and ERPs and cortisol measurement. I thought it was very interesting. We have a study going on here. It's for First Episode Psychosis, and it's looking at reducing dupe. And when the grant was submitted to the National Institute of Mental Health, they did fund the grant, but one of the caveats that they asked for before they approved it was that one of these at-risk assessments be included in that first episode work. And the reason for that was because they wanted to ensure that we weren't over-diagnosing first episode work. So we look at using the at-risk assessments to predict if someone's at a higher risk. But I thought it was really interesting that they saw it as a protective measure so that people weren't being overdiagnosed with first episode psychosis. And it is very crucial during the assessment period that we provide education to these people about their symptoms, about the duration of the symptoms, about the risk associated with the symptoms, and most importantly, that we talk about lifestyle choices and the impact they have on potentially changing those, the progress of their illness, stress, substance use, things like that. The PACE writing group discussed this risk of false positives, and as I mentioned earlier, that was a big criticism of this work 10 and 15 years ago. And what the PACE writing group found was that the stigmatization of people being identified as being risk, that was what people were afraid of. And what they found in their clinic is that they did not observe that happening in clinical settings, that they did not see people being subjected to that. And that what really had to happen was that these people got a clear explanation of what the at-risk phase really meant, that it meant that they had a slightly increased risk for developing a psychotic illness than the general population, and that you needed to be very clear with people. Does this risk exist forever? And if you don't meet the risk in this assessment, does that mean you never have to worry about meeting it? So those are crucial pieces of the psychoeducation that occurs during the assessment phase, and that it is very, very important to treat any presenting symptoms and disability that exist in that pre-risk phase, that pre-psychotic phase. And again, the American Psychiatric Association in 2004 basically published the same things that later the PACE group was in 2012. The American Psychiatric Association was in 2004. And at that time, they supported the continuing research in this area. They felt there was a positive benefit to risk ratio in treating these people. And their recommendation was that clinical strategies should include frequent, careful follow-along evaluations with psychoeducation and support over the course of the prodrome or at-risk phase to its resolution, regardless of whether that resolution was remission or the development of a treatable syndrome. And they also recommended treating co-occurring disorders as appropriate and in keeping with the established guidelines for those illnesses. it's very important when you're thinking about the benefits and the risks of treating people in this phase that you recognize there are two equally important purposes for treating people. One is certainly to try and prevent the first episode of psychosis, and the other is to prevent the development of a persistence of functional deficits, so social, educational, or vocational deficits. The most, I think, important argument in favor of intervention in the at-risk phase is the distress that these people feel. These symptoms already exist for these patients and are either causing them internal distress or are interfering with their day-to-day existence, and they need help with that. CBT is regarded as the first intervention to prevent conversion to psychosis, and that's followed by a staged intervention complemented by pharmacological interventions with low dose of second-generation antipsychotic medication for stabilization of symptoms. It's just as important to address the current individual needs of that young person and other mental disorders or comorbidities that may be present, especially depression and anxiety. So 73% of people who meet the at-risk phase have comorbid diagnoses, Axis 1 comorbid diagnoses. 41% it's depression, 15% it's anxiety. So it's important if people have those comorbid diagnoses that we are treating them in this at-risk phase because of the stress vulnerability nature of the at-risk phase. So if we can lower their depression and their anxiety and improve it, we're lowering the stress to the individual. And by doing that, we will lower their at-risk symptoms as well. And the other thing that's really important is to look at the person's individual needs. You know, sometimes when people present at a clinic and they say, I'm hearing voices, we automatically assume that the first thing we need to treat is the voices. And that might not actually be the symptom that is most problematic to the young person. So we really need to take into consideration what are their individual needs in helping them to feel better. And this was developed by the European Psychiatric Association, and it really is the first evidence-based treatment guidelines for first episode for at-risk clinical high risk. And they felt that in addition to being a guideline for care, it also made a very strong argument for the importance of individualization of treatment. And again, this was very quickly validated by other programs, and it is generally now accepted that the aims of treatment in the at-risk state are really threefold, not just to prevent or delay the decline into frank psychosis, although that is certainly one of them, but the aims of treatment are to reduce symptoms and disability and to improve social, occupational, and educational functioning in these young people. There are certainly other potential benefits of early treatment. I think one of the most interesting things that came out of the Australian work was that people with these at-risk or sub-threshold psychotic symptoms were able to engage more quickly with treatment than those who presented after psychotic symptoms crystallized. And I think that's very important because if they're able to engage in their treatment, as I mentioned earlier, the treatment has a much better chance of being successful. The other thing they determined that people who were already engaged with a clinic for at-risk symptoms. If they did become fully psychotic because they had been previously engaged, they were able to develop and accept treatment easier than their counterparts who didn't have that prior engagement. The earlier development of a therapeutic relationship with a treatment team for at-risk is going to make the person more acceptable to further intervention. They're going to, clinics who address both at-risk and first episode are going to be able to provide rapid access to treatment. There's going to be that seamless transition to their provider and therefore a reduction in the DUP, which we know is crucial. And the other thing that's important here is that treatment during the at-risk phase helps to drive new strategies for improving the prognosis of at-risk people. And of course, we want to continue to do that. There have been many, many studies done that look at the efficacy of interventions in the at-risk phase. And just to give you some sense, these have varied starting in 2004 with the British study and ending with the study in Austria in 2010. The PACE study in 2007 compared combined CBT and low doses of atypical antipsychotic with usual care management, and it demonstrated that psychosis onset could at the very least be delayed by the specific intervention. The PRIME study back in 2006 compared 12 months of an active treatment low-dose antipsychotic with placebo. Now, the outcome of that study was not to recommend that particular antipsychotic because of the horrific weight gain that was associated with it, but that low doses of antipsychotics could absolutely reduce the disability from the symptoms. The British study was a randomized CBT for 6 months as compared to monitoring of their mental state, and the CBT was associated with a significantly lower rate of transition to a full psychotic disorder. So CBT, there was a 6% as opposed to monitoring where there was a 26%. And there was a significantly greater reduction in psychotic symptoms at the 12-month point. The study from Germany was a randomized trial of cognitive therapy as compared to supportive counseling. Cognitive therapy was found to be superior in reducing the progression to full threshold psychosis over a 24-month period. And then the study in Austria was a randomized trial of omega-3 versus placebo, and the omega-3 treatment was associated with a significantly lower rate of transition to psychosis through the 12-month follow-up period. And there have been many studies that I haven't quoted here, but the important thing is that they are replicating one another, and we are finding the same outcomes. The engagement phase of treatment is certainly very, very important. One of the things we want to address during that period is communication skills. And we know that at-risk patients have difficulty with communication skills. They can't follow multi-step directions. So active listening and communication clarity really become crucial in this engagement period. We need to be flexible in the style and the delivery of the information that we are providing and the education about the at-risk phase. So, we don't have to force them to accept that they are at risk of developing psychosis. Rather, we need to feed back to them the types of symptoms and things that are interfering with their day-to-day life and how we may help keep them in check or what can be done to prevent them from getting worse. Patient-driven treatment plans are crucial. As I mentioned earlier, it might not be the voice that is most distressing to this person. It might be their lack of sleep or something else. And so we really want to focus our treatment plan on their individual needs, allowing the patient to identify the symptoms that they most want help with, and then to identify the problems with their day-to-day functioning that they want to work on. And eventually that can progress to issues they might not have considered, like the possibility of developing psychosis. And again, with the consent of the young person, it's very important to work collaboratively with the family and the school. We do psychoeducation with all the families of our at-risk patients. We help them, we teach them how to communicate more effectively with their patients, and we always get such positive feedback on that because their family has begun to think that they're just oppositional and not listening to them anymore. And when we help them understand that these young people can't follow multi-step directions, they're like, oh, my child is back. They're more cooperative again. And the same in the schools when we go into PPTs and we work with them to help understand, break down their assignments one step at a time. Don't sit them next to the window in the classroom where the bright sunlight's going to distract them. Let them go 30 seconds before the bell rings so they don't have to maneuver the halls with all the chaos and noise, so they can get to their next class, sit down, and be able to attend and focus easier. They're simple little engagement tools that help these young people to be more successful. You absolutely want to make sure you talk about the wellness issues. You want to make sure you have a full medical and medication history so you can rule out that these symptoms might be driven by a medical condition or a medication. Many young people suffer from acne, and Accutane is often prescribed to treat the acne, and it has been linked to increased psychotic-like symptoms, so we want to make sure we understand their medical background. We want to, are they overweight? Do they have high triglycerides? Are they very sedentary? So we can assess their risk for metabolic syndrome that might accompany the use of the atypical antipsychotics if they were to progress to the point where that were needed. A full medical exam, some blood work, make sure we're not dealing with B12 deficiencies or vitamin D deficiencies. If the person has a history of a severe head injury or not severe but 5 or more head injuries, we might want to recommend a neurological exam for them. Height, weight, blood pressure, urine or blood drug screening. And certainly we want to educate all of our patients on the 5 steps for wellness. So hydration, nutrition, exercise, good sleep, and stress management. The importance of monitoring, there is certainly a need for regularly scheduled follow-up assessments. Obviously, the most important thing about identifying these people early is to halt the progression or the worsening. If we don't have a good picture of where that young person is at baseline, we don't have anything to measure it against. So we really need to get that thorough baseline picture of where they're at and then monitor for progression. And as I mentioned earlier, certainly progression and worsening so that we could intervene, but also for those nuances of improvement. so that we can show that indeed the intervention is having a difference, is making a difference. And feedback to the patient and their family is a crucial component of the monitoring. It really helps to reassure them and give them confidence in the work that you're doing with them, and help them to feel hopeful and feel good about what they're doing. Emphasis, you want to emphasize the fact that progression is not inevitable and that the monitoring can help alleviate their current problems, and timely interventions, should those problems worsen, will be available. Monitoring visits can help clarify the difference between symptoms of the at-risk phase and all of those normal developmental challenges that accompany adolescence and early adulthood. And monitoring visits can emphasize the importance of lifestyle choices on the course of the illness. We certainly don't want our patients to have a deterministic attitude. Oh, well, I'm at higher risk, therefore there's nothing I can do to impact the course of what's going to happen to me, because we know that isn't true. There are individual interventions that can be used, certainly sit therapy, supportive interpersonal therapy, cognitive behavior therapy, communication skills education, problem-solving skills education, education about the stress vulnerability model of this illness, and helping patients to identify what are their stress triggers, where do they locate stress in their body, and what are effective ways for them for dealing with stress when they are stressed, because each of us deals with it different. I might want to meditate, you might want to go run for 5 miles, somebody else might want to punch a punching bag for a while. You know, there's no one way of stress management that is definitive. We all have different ways of dealing with it. Supportive interpersonal therapy involves education regarding the at-risk symptoms, specifying things that are protective to the symptoms worsening. As I said, education about the impact of stress on this, the importance of treatment compliance, of course, making an individual symptom reduction plan. So there's a plan for each of the most distressing symptoms that the young person has, so they can really see where their work is making a difference. Education on how the family and the school can help support their work. And all of this has been outlined in a treatment manual for brief supportive education with this phase of the illness. Cognitive behavior therapy, I mean, certainly the way people think and interpret events determines how they feel and what they do. Cognitive distortions contribute to maintaining the psychotic-like symptoms that these young people experience. Poor coping strategies also contribute to maintaining these strategies, and these are all things that would be addressed by cognitive behavior therapy. You know, people can't have a feeling without first having a thought, but our thoughts are automatic and they're based on our past experiences, and they contribute to forming our belief system. So understanding that correlation between our automatic thoughts and our feelings and our behavior is a crucial piece of the CBT work. And developing more adaptive and realistic thoughts is a very, very good coping strategy for these people. There are some other potential benefits of CBT in the at-risk state. It assists in forming a therapeutic alliance It assists in achieving clinical stabilization, a reduction in the intensity or perhaps the frequency of the attenuated positive symptoms, because again, we always want to remember that a worsening of the at-risk symptoms can be defined certainly by an increase in the intensity of the symptom, but it also could be an increase in the frequency or an increase in the level of distress or interference. Those are all ways that at-risk symptoms can certainly worsen. So we can reduce those things by helping their level of distress go down or providing alternative coping strategies. And of course, the less stigmatized we are by our symptoms, it's going to help protect our self-esteem and our self-worth. And it is going to reduce that risk of being stigmatized. And again, CBT in the at-risk phase can also prevent comorbid diagnoses from developing. Communication skills, this was defined in the Family-Focused Therapy Manual published by Dr. O'Brien. It really addresses the communication skills that are crucial in working with the at-risk population, helps the people around them, their family and themselves, learn how to express positive feelings, giving skills on active listening, so we're not always trying to solve the young person's problem, but just giving them a safe environment to vent about things. Communication clarity, as I said, reducing multi-step directions and things like that. There's certainly going to be times when behavior needs to be changed, and the communication skills helps you to teach people requesting the change how to make it in a more positive manner so that the young person does not get defensive and fight it. And, positive ways to express negative feelings about those specific behaviors so they don't, feel stigmatized or criticized. Probably criticized is the better word for those things. The stress vulnerability, and again, I can't emphasize this enough, this actually caused us to redefine remission in the at-risk phase, because initially we felt that if all the positive symptoms went below the at-risk phase of ratings, that a person was in remission. And what we quickly learned is that in July, all of our patients were in remission, and it was directly related to the fact that they weren't in school. And so their stress was reduced and their symptoms resided. So what we have to do is now define remission. That would only be a partial remission, and a full remission would only take place if those symptoms were under the at-risk level for greater than 6 months. So making people understand how their stress levels is going to impact their symptoms is crucial, because they won't get blindsided if their symptoms worsen. They'll be prepared for it, so they can put some coping strategies in place to deal with that. And again, it helps them identify not only the psychological impact of stress on them, but the biological and social factors as well. Stress education, again, I can't stress it enough. We need to help our patients know what are their stress triggers, where stress impacts in their body. Do they get a headache, a tummy ache? Do they get muscle tension? And then how they can cope with it. And they should have a whole arsenal of coping mechanisms as opposed to just one go-to. Sometimes distraction in the moment is the best form of stress management that is available. And as I said, then you can go up the roster of physical exercise, meditation, sometimes even focusing on a video game for a short period of time. That distraction might actually help them with their reducing their stress levels. And sometimes parents don't realize that, and so they can never find a positive reason for someone to play a video game or do something. And so we try to help, parents recognize that within reason and limitations, it might actually be helpful. Family interventions, again, based on the stress impacting the exacerbation of symptoms in at-risk patients, their family members' stress level, especially in younger patients, can also impact the patient's symptoms. So we need to help educate the parents and the family members about that. And the offer of support and information about this high risk for psychosis and the presence of what comorbid symptoms their young person might be having should be provided to the family members in order to reduce the family members' level of distress and encourage them to avoid criticizing or stigmatizing the young person. Of course, you always want to consider confidentiality in disclosing specifics of the young person's symptoms to the family. So that has to be an open dialogue that you have with the young patient. And structured family interventions may be needed, such as family-focused therapy or multifamily groups. Information on both those forms of intervention are published. Dr. Mary O'Brien for family-focused therapy, Dr. William McFarland for the multifamily group. Group interventions certainly have been found to support young people by enhancing their strengths and working on their personal goals. Vocational groups that focus on their performance in school or work can be helpful for these young people. Improving health through physical fitness, stress management, and substance use education reduction is important. Social groups, focusing on social skills and getting a little practice, interacting with other people, just like activity groups, joining a pottery class or an art class or anything along those lines, groups aimed at developing independence or assertiveness skills. Anything that helps a person improve in their self-esteem, their social anxiety, their anger management, any way we can help them with those comorbidities is also going to help them with their at-risk symptoms. Crisis management must always be a part of early intervention programs because significant crises do occur even without meeting full-blown criteria for a psychotic disorder. We always need to be assessing the risk of harm to self and to others. But we also want to monitor other risks of other aspects of risk, such as the risk of that patient being neglected because their support system has burned out in caring for them, or perhaps even the risk of them being a victim because of the way that their symptoms interfere with their ability to protect themselves. It's important that when we're doing these ongoing assessments that we're always communicating the results of these assessments, not just to the family and the person, but to the other providers involved in the care of that young person. And we always have to be very clear that we outline for them what the emergency services, after hours, services are, if you have a crisis line, or if your recommendation is that they call 911 or 211 or, whatever might be available. We don't want to assume that because a person isn't fully psychotic that they might not need some crisis management along the way. We want to work with people to, we're going to alter our treatment plan for these young people if they do go into remission, either a partial remission or a full remission. So with partial remission, we really want to focus on the potential for it worsening again and how we don't want them to be blindsided by that or have it impact them negatively, like, oh my God, I'm backtracking, that what we expect is an increase and a decline in symptoms throughout their lifetime, but the overall trajectory of the increase and the decline should be in an upward movement. When we get concerned is when we see the increase and decrease in a downward trajectory, and that would significantly change our treatment plan. And again, a full remission would be when their symptoms are below an at-risk phase of threshold for greater than 6 months. And, we want to deal with that a little bit differently because even a full remission under an extremely high stress time could go back into the at-risk phase. And transitions or cusps are when young people become most vulnerable to those exacerbations. So moving from middle school to high school to college, high school to the military or a job, college to graduate school or to the military or a career. Any of those transitions make a person more vulnerable for an exacerbation. And we want them to be prepared. You know that old adage, forewarned is forearmed. We want people to recognize that their symptoms may increase. So they have a plan in place. What worked for me in the past? What are some of the strategies that I used that helped me get this under control so that you go back to the work? I always tell my patients it's like being on a diet. You go on a diet, you're very strict with it, you lose the weight. And then eventually you're not so strict on the diet. And so maybe your jeans get a little tight. That doesn't mean you panic. You just go back to utilizing the skills that you had when you were on the diet so that it can help you, keep it in control. And of course, even though they're in remission for their at-risk symptoms, we still want to stress the importance of continued treatment for their other comorbid diagnoses if they exist, specifically anxiety and depression. And then if you're working with the at-risk population, you have to have a plan for handling conversion, because just because you're providing treatment in this at-risk phase does not mean that you're definitely going to prevent conversion. So the very first thing, again, as I mentioned earlier, is that definition of what you consider to be that fully psychotic first episode threshold. And you want to plan for treatment transition. And again, this is why we really strongly recommend that if you're going to have a first episode clinic, that you have an at-risk clinic as well. And if you're going to have an at-risk clinic, that you also have a first episode clinic. Because the likelihood of a person transitioning from one into the other is high. And if you have both clinics, it's truly a seamless transition, and it seems less significant to the patient. They can be more accepting of the treatment and more active in their treatment plan. The other thing is you also want to differentiate between the intensification of existing symptoms and the emergence of new symptoms. So you may find that some of your patients, the symptoms just gradually increase and get worse, whereas sometimes at-risk work will keep the existing symptoms in check and they don't worsen, but then new different symptoms emerge. So for example, somebody may have been showing some early warning signs, not fully psychotic, but in the at-risk phase of some paranoia. And you work with them on those, and they either decrease or don't continue to worsen. But then in the course of their prodrome, they start to have perceptual abnormalities. So just because you're keeping one of the positive symptoms in check doesn't mean you don't have to keep monitoring the other ones, because they could emerge as well. And again, that pre-existing engagement is going to further their treatment, because they're already going to be comfortable, they're going to trust you, they're going to feel that you have their best interest at heart, and that's going to make them feel better. And you always want to have a menu of first episode treatment options based on all the evidence-based theory that is out there, you know, in terms of medication management, individual therapy, family therapy, social cognition groups, education support, occupational support. I mean, all the areas that we know have been shown to be crucial to these young people doing better. So basically, I guess what I'd like to say in conclusion is that at-risk research in psychosis certainly provides us a rationale for service provision to those people in need of this help who previously could not have accessed it. So typically what happened in the past is these young people received treatment for their comorbid diagnosis, maybe depression, maybe anxiety, maybe their substance use disorders, but nobody looked at their whole total clinical picture. And by providing at-risk care, we can do that. We can look at that total clinical picture and provide treatment plans for each aspect of it. And that really changes the trajectory for those people who are vulnerable to a psychotic illness. And it also improves the quality of their life, whether they go on to develop a psychotic illness or not. And needless to say, that's nothing to, you know, raise our noses at. It's very important if we can help our patients to feel better and do better and just to get a better quality of life. So I guess we can now open it to questions.
Excellent. Thank you, Dr. Wash. So if you have questions, go ahead and put them in the chat box. And we do have a couple of questions to get us started off. Gita asked if you know of any assessments for children younger than 10 years of age who are reporting auditory hallucinations such as hearing voices.
I don't know any that are validated younger than 10 years old. So part of the process for standardizing these assessments is the verbiage used in the assessment, and none of it has held true with people under 10, at least not to my knowledge.
Okay. And then Tamara wants to, says that it's her understanding that the Australian guidelines for antipsychotics are that they're not indicated except at higher levels of symptomology where there is rapid escalation of symptoms. She just wants to know if that's a correct understanding or if there's another guideline that the participants should be aware of.
No, that is absolutely correct. It is for those people who are above the median risk of developing the psychosis.
Okay. And Susan wanted to know if the manual by Dr. O'Brien, the Family Focused Therapy Manual that you mentioned, if that's published, and if you know where it might be purchased, if it's not readily available in normal like online places?
You can absolutely obtain it on Abline. It's called Family Focused Therapy, and Dr. O'Brien is Mary O'Brien is the first author. And it's been available probably for a couple of years now, yes.
Okay. And similarly, the treatment manual that you mentioned for brief supportive psychoeducation, is that available for purchase or available somewhere else online?
I don't know that you can actually purchase it, but it is available in the published works of the Naples Consortium, the North American Prodromal Longitudinal Study. That is the manual that was recommended during those studies, and I believe it's been published and available.
Excellent. And then Ryan just wanted to know if you could define false positives when you were talking about assessments and how they could potentially be an issue. So just sort of.
Oh, absolutely. That's such a good point. Thank you, Ryan, for bringing that up. So in these assessments, the SIPs and the CARMs that help to identify whether a person is at risk, what it is saying is that you are at a slightly increased risk for developing psychosis than the general population. That does not mean definitively that you are going to go on to develop psychosis. So what we know is that there is a percentage, it varies, somewhere between 20 and 40% that go on to develop psychosis. But the rest of that 60% is divided into two groups. Some of them never get worse, but they never get better. And some of them remit all on their own without treatment. So a false positive would be someone who was evaluated and determined to be at slightly higher risk for developing psychosis, but then never goes on to develop psychosis. And as I mentioned earlier, the highest risk for developing psychosis is that in that first year, especially the first year, but also the first 2 years. But it has been shown that that risk could exist for at least 10 years. So usually at-risk clinics will follow their patients for at least 2 years to get them through the most vulnerable period for converting, and then may have less frequent follow-up with them after that.
Thank you. So Susan wants to know if you can describe a little bit about the training for SIPs and CARMs.
Okay, so I can certainly speak more intelligently about the SIPs because I provide the training. The CARMs I've only been trained on, so I don't provide the training for that. But both instruments have very specific conventions that you need to learn. I do believe the CARMs has a package that you can purchase online that includes the manuals and videos and practice for learning the assessment, as well as they provide in-person training. The SIPs, it is recommended that you have an in-person training. It typically is a 1 3/4 day training. But there is a book that was published out of the Prime Clinic called the Psychosis-Risk Syndrome Handbook, and that educates you about the SIPs, how to use it. There is an older version of the SIPs inside that book. So that is an alternative way to learning how to use the SIPs, although the SIPs is a copyrighted assessment, and so to get around the copyright, you really should be trained on its use.
Thank you. Tamara actually has kind of a follow-on question because it's about using SIPs. She notes that there's some concern with people being labeled as clinically high risk without going through a thorough diagnostic evaluation that could potentially screen out other causes. So what protections need to be put in place in order to make sure that when you're using SIPs, you're using it appropriately?
Okay, I'm not quite sure I understand the question, but again, the conventions to use the SIPs appropriately, number one, the young person must have a minimum IQ of 70. And again, that goes back to the verbiage that is used in the assessment, and so that it won't be valid if their IQ isn't 70. So that's the most important thing. The second most important thing is that the person that you're evaluating is help-seeking, so they already acknowledge that they are having some types of experiences or symptoms that are either distressing or are interfering in their functioning, and they want some help with it. And that would be when a SIPS would be warranted. So you would use a pre-screen to try and establish those benchmarks so that you knew you weren't using the SIPs needlessly.
Okay. Then she provides a little more detail, asking if a person has perceptual distortions caused primarily by anxiety or other diagnostic syndrome that could be confused with.
Oh, okay, I see where she's going with this. Okay, so that's an excellent question because, again, we mentioned earlier the importance of differential diagnosis. And a lot of experiences that could appear psychotic-like occur within the general population, especially perceptual abnormalities with young children. They have perceptual abnormalities that have nothing to do with a risk of developing psychosis. So one of the reasons that the training is so crucial for administering the SIPs is because the assessor has to determine, is this symptom a comorbid, part of a comorbid diagnosis, or is it part of the at-risk syndrome? So, for example, a young woman who's being assessed with a SIPS who has a trauma history of having been raped. So on P2, which is suspiciousness, she might rate very high. It's very important that the assessor not just take that as an indicator that they meet the at-risk syndrome. There are other conditions that must be met, one of which is that symptom better accounted for by another diagnosis? So, for example, did this suspiciousness pre-exist the rape? Or would they be suspicious of a child or an animal or something that would not be associated with her trauma? So that differential is very, very important. People can have comorbid diagnoses, but the comorbid diagnosis can't better account for the symptom that you're rating as at risk. And just because a person rates in the at-risk range does not mean they get the diagnosis of at-risk. There are other conditions that have to be met. The symptom had to begin or worsen in the past year. It has to occur at a defined frequency. It has to be distressing to the person or interfering in their functioning. So there is a list of other conditions that has to be met to get the diagnosis. So it's not just that the symptom exists at a certain intensity. There is other identifying criteria that must also be met to actually get the risk diagnosis.
Thank you. And Tamara also asked if you can tell us anything about the conversion rate over a 10-year period after a person has been identified as clinical high risk, she's recently been hearing that the majority of people identified as at risk will go on to convert eventually, but that it seems inconsistent with what's being presented in the literature.
Yeah, and you're absolutely right, Tamara. It is, and unfortunately, I think a lot of that had to do with some of the work only followed people for 5 years. And then later, when they went back and checked in with those people 10 years later, they found out that they had indeed converted. So I think initially in the early days of this work, we really kind of thought that first 5 years was the more crucial time for converting to psychosis, and if it didn't happen within that 5 years, you were kind of out of the woods. And we know now that that's not true. As I said, the first 2 years are the highest risk for converting, the first year especially, but we are seeing cases of conversion 6, 7, 8, 9, 10 years out. So it doesn't appear that the risk goes away in those 5 years as we originally thought.
Thank you. Looks like we have a question coming in from Susan, and just a reminder, we still have a little bit of time left for today's session, so go ahead. If you have a question, go ahead and put that in the chat box for Dr. Walsh. So Susan asked if you know what the statistics are for the conversion rates at 10 years.
Yeah, I wouldn't feel confident giving you a statistic about it. And the reason for that is I agree with Tamara. I've read very conflicting reports on it. The only thing that all the experts seem to agree on is that the risk does indeed still exist at the 10-year point. I mean, certainly it's lower than where it is in those first 2 years, but it does still exist.
Okay. And Tamara just mentions that, I hope I say this right, Fassar Pauly did a meta-analysis that addresses Susan's question about conversion rates at 10 years.
Yeah, that is absolutely true. It was one of the references in the earlier webinar that I did. It was a pretty intense meta-analysis, so it might provide you with some information that you feel more comfortable with.
Okay, well, if there are no more questions, I don't see anyone typing in the chat box. We're going to give everyone back this extra 7 days of their Friday, so use it wisely, go have some fun. We do want to thank Dr. Walsh for joining us once again and presenting on this topic that draws a lot of interest, as we can tell from the large number of folks who join us for each of these sessions. And we want to thank everyone who joined us today for taking time out of your Friday to come and hear what Dr. Walsh had to say about this very important topic.
And I want to thank you for all your help and support with the logistics of this and making it so easy. So thank you very much.
You're welcome. All right, everyone have a great day.
Okay, bye-bye.